Golden Notes, Chiari syndrome, a triad of abdominal pain, ascites, liver enlargement. You should always think about Chiari syndrome. This uncommon condition is caused by thrombosis of the larger hepatic veins and sometimes the inferior vena cava. Many patients have hematological disorders such as myelofibrosis, primary proliferative polycythemia, paroxysmal nocturnal hemoglobinuria, or antithrombin 3, protein C or protein S deficiencies, pregnancy and oral contraceptive use, obstruction due to tumors, particularly carcinomas of the liver and kidneys or adrenals, congenital venous webs, and occasionally inferior vena cava stenosis are the other main causes. The underlying cause cannot be found in about 50% of patients, although this percentage is falling as molecular diagnostic tools such as the JAK2 mutation in myelofibrosis increase our capacity to diagnose underlying hematological disorders. Hepatic congestion affecting the centrilobular areas is followed by centrilobular fibrosis, and eventually cirrhosis supervenes in those who survive long enough. So it is an obstruction of the main hepatic veins by thrombus. Chiari syndrome or hepatic vein thrombosis is usually seen in the context of underlying hematological disease or another procoagulant condition. As we have said, causes are polycythemia rubra, thrombophilia, activated protein C resistance, antithrombin 3 deficiencies, protein C and S deficiencies, pregnancy, and oral contraceptive pill. Now the clinical features. In fact, acute venous occlusion causes rapid development of upper abdominal pain, marked ascites, and occasionally acute liver failure. More gradual occlusion causes gross ascites and often upper abdominal discomfort. Hepatomegaly, frequently with tenderness over the liver, is almost always present. Peripheral edema occurs only when there is inferior vena cava obstruction. Features of cirrhosis and portal hypertension develop in those who survive the acute event. So abdominal pain, sudden onset or severe, ascites, tender hepatomegaly, and signs of portal hypertension are present, and patients may develop acute varicose hemorrhage as a complication. Now the investigations. Liver function tests vary considerably depending on the presentation and can show the features of acute hepatitis. Ascitic fluid analysis shows a protein concentration above 25 grams per liter. It is an exudate. In the early stages, this often falls later in the disease. However, Doppler ultrasound may reveal obliteration of the hepatic veins and reverse flow or associated thrombosis in the portal vein. CT may show enlargement of the caudate lobe, as this often has a separate venous drainage system that is not involved in the disease. CT and MRI may also demonstrate occlusion of the hepatic veins and inferior vena cava. Liver biopsy demonstrates centrilobular congestion with fibrosis, depending on the duration of the illness. Venography is needed only if CT and MRI are unable to demonstrate the hepatic venous anatomy clearly. So ultrasound Doppler or contrast CT scan is often used to make the diagnosis. Hypertrophy of the caudate lobe on imaging is a characteristic sign but is seen only in 50% of cases. Ascitic type usually demonstrate a high serum ascites albumin gradient, more than 11 grams per liter. Now the management. In fact, predisposing causes should be treated as far as possible. Where recent thrombosis is suspected, thrombolysis with streptokinase followed by heparin and oral anticoagulation should be considered. Ascites is initially treated medically but often with only limited success. Short hepatic venous strictures can be treated with angioplasty. In the case of more extensive hepatic vein occlusion, many patients can be managed successfully by insertion of a covered tips, followed by anticoagulation. Surgical shunts, such as portacaval shunts, are less commonly performed now that tips is available. Occasionally, a web can be resected or an inferior vena cava stenosis dilated. Progressive liver failure is an indication for liver transplantation and lifelong anticoagulation. So in a brief talking, management is thrombolysis and subsequent anticoagulation. Now the prognosis, 3 years survival in patients with chronic Chiari syndrome has been reported as 50%. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. The golden notes sources are Davidson, Oxford Handbook series, Essential Revision Note for Mrcp, and Notes. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.